Have you ever wondered what aortic dissection is and why it's considered a serious health condition? Well, let's unravel this mystery together. Aortic dissection is a rare yet serious medical condition often identified as a cause of chest pain. It's associated with a variety of factors such as hypertension, trauma, and even some syndromes like Marfan's and Ehlers-Danlos. It's a complex and intriguing subject that deserves our attention. Stay tuned as we dive deeper into the pathophysiology of aortic dissection. So, what exactly happens during an aortic dissection, you might wonder? It all begins with a tear in the tunica intima, or the innermost layer of the wall of the aorta, the largest artery in your body. This tear can be triggered by a multitude of factors, with hypertension being the most significant risk factor. Other associations can include trauma, a bicuspid aortic valve, or certain collagen disorders like Marfan's syndrome and Ehlers-Danlos syndrome. Even conditions like Turner's and Noonan's syndrome, pregnancy, and syphilis can be linked to this tear. Now, once this tear forms, the high-pressure blood flow within the aorta can force its way into the wall, separating the layers within the aortic wall. This creates a false channel known as a false lumen. Imagine a highway splitting into two lanes with traffic, or in this case, blood, being diverted into this new false route. But why is this a problem? The creation of this false lumen can lead to a series of complications. For one, it can restrict blood flow to the body's organs and tissues. Picture a city with its main road blocked. The distribution of resources would be severely hampered, right? Similarly, organs like the heart, kidneys, or brain may not receive the essential blood supply they need, leading to severe organ damage. Furthermore, the false lumen can expand over time, putting the aorta under immense strain. This strain can lead to the rupture of the aorta, a life-threatening situation. It's similar to a balloon being overfilled with air until it can't hold anymore and bursts. Understanding the pathophysiology helps us recognize why aortic dissection is a medical emergency. It's not just about a tear in a blood vessel, it's about the domino effect that this tear can trigger, leading to severe complications that can put a person's life at risk. Aortic dissection is therefore a condition that demands immediate medical attention and intervention. Now that we understand the pathophysiology, let's look at the key features of aortic dissection. Aortic dissection often presents with chest or back pain, described as severe, sharp, and tearing. This pain is typically at its worst right at the onset. Depending on whether it's a type A or type B dissection, you may see more chest pain or upper back pain, respectively. However, it's important to note that there's a lot of overlap, and many patients will experience both types of pain. Next, we have the pulse deficit. This is where a weak or absent carotid, brachial, or femoral pulse comes into play. There may also be a significant variation in systolic blood pressure between the arms, more than 20 millimeters of mercury to be exact. Aortic regurgitation and hypertension are also common features. But what's interesting is that the symptoms can change depending on which specific arteries are involved. For instance, if the coronary arteries are affected, the patient may experience angina. If the spinal arteries are involved, we might see paraplegia. And if the distal aorta is involved, limb ischemia may occur. Lastly, while most patients do not show specific ECG changes, in a minority of cases, ST segment elevation may be seen in the inferior leads. Recognizing these features can be crucial for early detection and prompt treatment. Aortic dissections are not all the same. They are classified into different types. Let's delve into the two most recognized systems, the Stanford and DeBakey classifications. The Stanford classification divides aortic dissections into type A and type B. Type A involves the ascending aorta, accounting for 2/3 of cases. Type B, on the other hand, affects the descending aorta, distal to the left subclavian origin, making up 1/3 of cases. The DeBakey classification is slightly more detailed. Type 1 originates in the ascending aorta and propagates to at least the aortic arch, possibly going beyond. Type 2 is confined to the ascending aorta, while type 3 originates in the descending aorta, rarely extending proximally but can extend distally. These classifications aren't just academic exercises. They're crucial in guiding treatment strategies, as different types of aortic dissection may require different medical and surgical approaches. Understanding the classifications of aortic dissection can guide the medical approach to this serious condition.